I just want to say hello to everybody and welcome to the HCV Action Hepatitis C Services in Wales, COVID and beyond. So my name is Rachel Halford and I'm the CEO at the Hepatitis C Trust. And I'm really delighted to be here today and to welcome you. The last time that we had a HCV Action, it was actually a roadshow and we had it in Cardiff. I think it was probably 2017, 2018. And Delith will remember this, that we were in a hotel. I just remember the hotel, and it was a really busy in-face interaction with lots of nurses, lots of substance misuse staff. So today we're on a webinar, and COVID has changed everything. So I'm just going to give you a really brief introduction, and then I'm going to hand over to the speakers. So Wales has a dedicated clinical team who have achieved an enormous amount in tackling hepatitis C. However, Wales has not benefited from the same level of financial backing that's been afforded to or seen in England following the NHS elimination deal. And I think that's what's really important we can't avoid not mention is COVID. COVID has had an enormous impact. The pandemic has had a massive impact on hepatitis C services in Wales. And this has actually further set back the progress with elimination. So hopefully what we're going to be able to do today and what we'll do in this webinar is we'll hear about the current state of play and where we need to go from here to progress towards the elimination targets. We have some fantastic presentations for you. Just a little bit of housekeeping. There isn't an option, unfortunately, to speak, but there is a chat box. So please, if you have questions as we go through the sessions, just write your questions into the chat box. I'll try and pick them up or into the Q&A box. I'll try and pick them up and we'll have an opportunity to ask the questions. And just to say also that we are recording the session, so there'll be an opportunity to listen to all of the presentations after the sessions, and the recording will go up on HCV Action website. So I'm just going to hand over now rather than waffle on myself. So it gives me great pleasure to introduce you first and foremost to Brendan Healy. Brendan is a consultant in microbiology and infectious diseases at the University Hospital of Wales and the lead clinician on bloodborne viral hepatitis lead for Wales. I think, Brendan, you probably don't need that spiel beforehand because I'm sure most people here will know who you are. So Brendan, I'm going to hand over to you. So hepatitis C services in Wales and the current situation.
Thanks, Rachel. Yeah, so I'm going to do an introduction by just running through the current situation in Wales. I've put at the bottom the slide that shows the 4 principles of prudent healthcare, which is something that we adhere to in this programme. Next slide, please. My disclosures are listed here and they're all visible on the internet. I'm signed up to that full disclosure around disclosures. So if you want to look, you can look me up. Next slide, please. So I thought I'd start by talking a bit about what the goal of the bloodborne virus team in Wales is, and specifically in relation to Hep C. And the first bit is really to say that we work as a team, and that's probably been our biggest success and our biggest achievement is what a successful team we have. And we're looking to help disadvantaged and marginalised communities to treat and cure people of hepatitis C and to reduce the incidence of cirrhosis and HCC and thereby help the wider community. And I think that last bit is really important as well, actually, because the work that we're doing by helping disadvantaged and marginalised communities and by reducing the risk of Hep C related liver disease in the long term does help everybody. It reduces pressure on the NHS for limited resource, it reduces cost, it's highly cost effective, and it reduces the risk of hepatitis C spilling over into the wider community. And we're also looking to achieve, one second, there's a chat popped up so I can't read my own slide, to achieve something worthwhile, show leadership and practice responsible and compassionate healthcare. And I think that's something that we've really achieved and something we can be really proud of. Next slide, please. So quickly to talk a bit about our successes as a team. this is similar to the first slide, really, in terms of how effective we've been as a team. And we have established a national network with equal and transparent access to treatment and care, which is quite phenomenal, and something that has gained us some attention, and other areas of seek to replicate, I would say, because eliminating postcode prescribing back in 2014, when the drugs first became available, was a huge success, and no health board was looking to deliver care, to benefit from discounts over and above other health boards. We worked together, and everyone in Wales had access to the same treatment. We do have a true national partnership with patient at the centre of all of our decisions. And we have universal access to medication, which means we're free to choose the right medication at the right time for the right patient. And this is something that isn't available in England, and we're grateful to Welsh Government really for providing us with this, with access in this way. And I can see why, a focus on cost of drugs might lead people to try to direct treatment options. But I don't actually think that's the right way forward. I think getting the right medication for the patient in front of you is the right way forward. I think that's cheaper in the long run, because you're more likely to be successful. And that's what we have in Wales. Next slide, please. We have a couple of UK firsts. We achieved micro-elimination in Swansea prison, which was the first time that had been achieved in a remand prison. And we've taken that strategy that was highly successful, and it's now operational in Swansea and Berwyn, and we've got funding to roll it out to Cardiff prison next. And the goal over the next couple of years is to achieve elimination of hepatitis C in all our prisons. And we're the first in the UK to start using kidney transplants from individuals known to be infected with hepatitis C, and then eradicating hepatitis C from the recipients. And again, that was at least partly down to the availability of medication and our freedom to choose how to use that medication and use it in the right setting. So again, grateful to Welsh Government for giving us that access, and then obviously grateful to the individuals that drove that programme forward. And we're still a UK leader in that regard. And I don't know the exact number, but I think maybe 20 or more patients have benefited from this access to kidneys already. Next slide, please. I was then going to talk about some of the platform building that's gone on. We've got key performance indicators for testing in harm reduction services, also key performance indicators for health boards, and we have a national specification for testing in pharmacy. So that lays the groundwork that will enable us to improve our testing rates, improve our delivery of treatment, and drive us towards elimination. Next slide, please. In terms of treatment pathways, I think we've also got lots of success in that regard. The national network, the funding that we've attracted from various sources, and the way we've run programs and not research, but projects, the way we've run projects across the country has enabled us to develop some successful treatment pathways. We have an accelerated treatment pathway, which is now available for use in both the community and prison setting. And this means that patients can access treatment much more easily than they would without the pathway. Some time back, we developed PCR on dried blood spot testing. That meant anybody who had a dried blood spot test would have, we would know whether they were PCR positive or not. And then also recently we've done a project looking at PCR from microtubules, and we're looking to roll that out in the prison setting and also in the community setting. That's successful, and that will improve access to diagnosis. And we did carry out a look back exercise, and we had around 10% engagement. There's still some work to do from a look back perspective. And the 10% engagement surprised me a little actually, but I would consider that successful. Next slide, please. What about some awards? Well, we were the BMJ Clinical Leadership Team of the Year in 2020. something to be really proud of. And that came down again really to the teamwork across the country, everybody taking part, the fact that we were providing equal access across the country, our prudent healthcare approach, all of those things were taken into account. So that was a proud moment for the team. And recently in BCU, they were the winner of the Improving Public Health Outcomes Award at the Advancing Healthcare Awards. And that was based on the point of care testing using PCR testing in a community homeless centre, aiming for micro-elimination. So that's similar to the pathway that we're using in the prison setting. And yeah, well, congratulations to the BCU team for that. Next slide, please. I don't know what that slide means. I obviously wrote it, but I've forgotten what I was on about. Yeah, we'll skip that one whilst I think what we were talking about. Oh yes, okay. So this is what we're talking about. Yeah. So that was just a slide to say that we've got data that treatment does have the impact that we want it to have in terms of improving outcome. So this is a bit old and it's UK data, but it shows clearly that after the introduction of DAAs, that patients listed for liver transplant as a consequence of hepatitis C dropped dramatically. And you know, that was in the early days with the early drugs, and the impact of the current drugs, which were even cleaner and more successful, is likely to be greater than this. And what it really means as well is that liver transplant is a scarce resource, and if it's not being used for patients with hepatitis C, they can be used for patients with other conditions. And that's really where the impact of our program starts to have an impact on the wider community, which is also good to see. Next slide, please. And this is similar data, again, a bit old, but showing the same things, that actually on a UK level, the impact of DAAs reducing deaths related to hepatitis C. So we have got data not only that the treatment works, but actually that the treatment programs, when they're rolled out, have an impact on big outcomes, such as the need for liver transplant and death. Next slide, please. Okay, I put suboptimal. That's polite for saying where we could be doing better. And really comparing ourselves with other UK nations. So I don't think there's any doubt that England's approach with a central fund to drive elimination is having a big impact in their success across England. And without that central fund, we're really reliant on teams working incredibly hard. We're constantly scrabbling around for funding to deliver some of the initiatives that we've put together. I'm really proud of where we've got to without any central fund. And I see it as a big gap really in terms of Wales's endeavour to achieve elimination. If it's serious about achieving elimination, I think it's going to have to reconsider the need for a central fund to drive that. And in terms of data collection, Scotland are way ahead of us. They have really good data demonstrating the effect of their programme. And if we're serious about delivering elimination, we need really robust data. We even need the sort of basic robust data to know how many cases of hepatitis C there are in Wales as a starting point, so that we know when we've achieved elimination. But we also need good data on the success of treatment, etc. And with that data, we'll also be able to show the impact that we're having in terms of cost saving from, again, liver transplant, cirrhosis, expensive management of end-stage liver disease, deaths, etc. Next slide, please. So as just a quick reminder, I think most people know this, that the global elimination aims are to eliminate viral hepatitis as a public health problem and to reduce new infections by 90% and deaths by 65% by 2030. Next slide, please. So Gilead commissioned a report recently, this year, or last year now, sorry, 2021, to look at where Wales was in terms of being on track to deliver elimination by 2030. They commissioned it through an external agency. Next slide, please. I'm not going to go through all the key analyst inputs and assumptions because it would take too long. But whenever you're looking at modeling data, it's you have to bear in mind that it's based on various assumptions, and I can provide them to the audience if they want to look through them at a later date. Next slide, please. We had a report looking at two starting figures. So one was 12,000 patients that we needed to treat, and another was 8,300. 12,000 is the figure that's generally quoted in the literature. 8,300 is where we think the true figure might be, but it could be anywhere between 8,300 and 12,000 really. And then the different strategies. One was continuing at our current rate. Another was managing to hit our current target of 900 treatments per year. Another was doing that, but with a focus on people who inject drugs. And another was an elimination strategy, in this case, 1,000 treatments per annum. So only 100 more than we actually are aiming for an elimination strategy. Next slide, please. And this slide shows how many patients would be treated per year with each of the strategies. And you can see that the elimination strategy, you treat more up front and then fewer later on, and vice versa. Next slide, please. And this is essentially the reaching the elimination target from a new cases perspective. And you can see that the black line, that's our current treatment achievement, and we're going to miss elimination by some margin at that rate. If we were to hit our 900 per year or 1,000 per year with a focus on people who inject drugs, we would likely hit target by 2030. Next slide, please. And then in terms of disease prevalence, it's a similar picture. With our current strategy, we'll miss elimination. With a strategy which meant we hit the targets that we're supposed that we would like to be hitting, sorry, we're more likely to achieve elimination by 2030. Next slide, please. Okay, we'll skip that because of time. Next slide, please. These all show the same thing, basically. The more people you treat, the quicker, the better it is in terms of achieving elimination, reducing mortality, reducing reinfection rate, and overall the cost is approximately the same in most settings. There's more of an upfront cost with the more people being treated, but overall, actually, the quicker you achieve elimination, the cheaper it is in terms of total cost. Next slide, please. Just a reminder of the individuals that we really need to reach, the performance enhancing drug users. We haven't done much work in that setting yet. Previous intravenous drug users, some of whom are long since retired. The PWID group that we're working actively with, homeless, chemsex users, all active engagement there. Immigrants from high prevalence countries, still more work to be done there. Asylum seekers, which we've got good contacts with, and children and young adults, which we'll hear about later. Next slide, please. So, that's a run through of where we are to date, what we've achieved, and we've achieved a lot, but what we've got left to achieve, and we've still got a lot left to achieve. What I think we really need, which is central funding to help drive elimination and better data. And just a reminder here that we always overestimate what we can achieve in 2 years and underestimate what we can achieve in 10. And I think that's probably demonstrated a bit by what we have achieved in 10 years. And it'd be nice to do even better over the next 10. Thank you very much.
Thank you, Brendan. That was a really comprehensive overview and really interesting as well. And important, the successes that Wales has had, and part of those successes is for us from the outside working with you guys is the teamwork that that you had together as a team. which leads me on really nicely to Delith, who's going to be talking to us the Bbv Recovery Wales. So Delith is a Bbv specialist nurse, PHW Cardiff and Vale University Health Board. Delith, over to you.
Thank you. Next slide, please. So just across the board, as we've all, well, this will resonate with most people, not just in the UK, but internationally as well, that Bbv work was significantly impacted by COVID, and some of the most vulnerable communities have been the hardest hit by this pandemic, and many of those are disproportionately affected by viral hepatitis. Next slide, please. So from some of the work that was done, it showed that Wales sort of did quite poorly, really, in terms of the impact of COVID. So many of the projects and initiatives were halted, but also that there was very limited or no testing frontline services due to reducing footfall and face-to-face consultations in substance misuse services and in prisons. We saw restricted laboratory capacity, processing DBSTs. Much of the work was suspended in terms of POCT work in order to support PHW laboratory COVID services. Many of the staff, including our colleagues, were redistributed to essential COVID testing, and we saw a shortage of specialist Bbv staff to enable us to provide outreach services throughout the network. Many of our colleagues were drafted to the front line to look after frontline COVID patients in intensive care, etc. So thank you. And a number of our key projects were halted, testing and treating in pharmacies, our re-engagement exercises, the REACH projects. But also we saw a rise in the incidence of hepatitis C, mainly due to high-risk behaviour, and also reduction in NSP services. Thank you. Next slide. So as a response, we set up a Bbv Task and Finish group, which we set up back in November 2020, with the aim of sort of looking at where we're at, what we can do to try and reinvigorate Bbv work, reinstate Bbv testing and treatment at Wales, and try and develop a very robust recovery plan, and try and navigate what we have and to improve the status quo. So it brought together representatives from all of the 7 health boards. We have clinicians, harm reduction leads, Public Health Wales, Welsh Government, and you'll be hearing from Michael later on, our pharmaceutical representatives, and of course the Hepatitis C Trust in the form of our very own Danny Morris. So we asked each health board to develop an operational toolkit to enable the Bbv recovery, of which we supported the implementation in order to share measures of success, what works, what doesn't work in the current climate. And also to assist the health boards to identify the key stakeholders to establish effective working relationships in order to maximise the recovery plan. And I think that was certainly the benefit of the Task and Finish group, was bringing together the harm reduction lead and the clinical teams around the table. Thank you. Next slide, please. So we've asked each health board to identify additional resources that would be required in order to facilitate the recovery planning process, which included workforce planning, any training and awareness raising materials that was required. It was noted that the Task and Finish group should also assist local teams in understanding the national testing capacity issues in the context of COVID. And we have very well-established links with our lab teams, which is really important to understand what capacity they have in order for us to keep processing the dry blood spot tests and carry on our work in the circumstances. And also to deliver on outcomes and health board plans to the viral hepatitis subgroup and our national meeting in October 2021. So that was the aim. It was to come together with a plan and present at the national workshop, which was fortunate that we were actually able to meet in person. It was great actually meeting everybody, all the health boards bringing together, led by Brendan. Thank you. So this is what our Task and Finish group looks like. As I said, we have representatives from Public Health, Welsh Government, all the clinical teams, the harm reduction teams, pharma and the Hep C Trust. Next slide. So as a starting point, we sent out 2 surveys to the clinical teams and also substance misuse services with the question, is there a crucial part missing that would enable you to screen and treat all patients within your health boards in order for you to achieve elimination? It was very well responded to. We had clinical services mainly commenting on the fact that the shortage of staff. A lot of the work has moved from just purely BBV to hepatology, which again, this limits the support nurses can offer outreach services, and the pressures obviously increase when staff are off or they've been redeployed. In terms of substance misuse services, again, it was a great response from them across the board. The majority of respondees were key workers. They're confident but welcome refresher training. A few of them acknowledged the importance of ongoing successful relationships with the clinical teams. There was some concern on the turnaround of tests, even before COVID, where some of the tests have actually gone missing and they haven't received the results. Staffing levels, they're concerned about the harm reduction database. For those of you who are not aware, we have a neo harm reduction database, which a number of the individuals were concerned that it can be long, the process can be long and difficult, and clients declining at the end of it. And 19% of them weren't kept informed of the BBV treatment of their clients, and would like recommendation or communication to be strengthened or progressed. So that was the first point from the survey. Next slide, please. So to address these issues, we looked at sort of the key elements sort of going forward to build upon these as a foundation to develop the recovery. So we took into account the training. So we offer monthly virtual online training sessions, which is very well attended, again, across the board. It's open to everybody, and we've had people from not just Wales, but England attending also. Follow-up sessions provided by the clinical teams to support the DBST rollout and actually help them with the practical side of things of driver testing. And the Hep C Trust have offered additional support and further sessions to maybe address some of the issues of if you have a difficult client who always says he doesn't want to be tested, but then we'll offer that support in order to get around that and support them. Thank you. Next slide. So, and one of the key elements, I think it's really important, is that each health board looks at their own health board, their own landscape, mapping and engaging of key services within their health boards, with the aim of each health board setting up their project teams to develop their toolkits based on a local needs assessment and what resources are actually required. Next slide, please. Importantly, information governance, which always raises its head. In order for us to share information with external services and agencies, we have developed a generic data protection impact assessment, which we hope can be adapted by each health board to enable us to share that information, and also the data sharing agreements. So hopefully that will just open up the doors to enable us to safely and securely share that information between services. One of the key elements that, as Brendan alluded to, was the fact that we need to improve the quality of our data collection, and obviously to enable us to evidence our progress towards the elimination target. We have 4 main platforms. We have the electronic e-form, which records the testing data that clinical teams input. We also have this near harm reduction database, which the substance use services record the screening and testing that takes place, and System 1, obviously in the prison setting. Just to go back very quickly, we also have a Welsh Health Data Mart, which draws from the e-form, which provides a weekly report, which shows us how we're actually doing our progress, which is really helpful. Next slide, please. So some of the key initiatives that we felt that we needed to do was to reinstate initiatives and develop further projects to achieve micro-elimination in high-risk populations. Brendan also also mentioned the re-engagement project. So we are about to start phase 2 of that, which is a more devolved approach, and looking at case finding. Just before Christmas, ICNet was launched, which flags up any patients who are admitted through the hospital doors who've had a previous positive either antibody test or PCR test to enable us to follow up. And that's been really helpful. It generates an alert for clinical team to follow up, so we can follow them up in terms of either treatment or certainly SVR bloods or further input. Sorry. Certainly we need to upscale our testing in substance misuse services to support the substance misuse teams in order for them to deliver against their KPIs, which I'm sure Michael will be talking about shortly. To look at population-based screening in our East Southeast Asian communities, traveller communities, antenatal care, and streamlining access to results. Again, this is something that we need to be working on to try and join up the lab reports in order to deliver the results to the clinical teams and the harm reduction teams in a timely manner. Excuse me. Looking at our treatment pathways, refining our treatment pathways to ensure that we can find and treat appropriately. Again, Brendan mentioned about the prison settings, that there are a number of initiatives in, obviously Swansea was the first prison to achieve microelimination. Berwyn is working, doing really, really well. We're looking at rolling this out in Cardiff, Park, and hopefully achieve microelimination across a prison estate in Wales. That's our ultimate aim. And also looking at children and young people screening and treatment pathways, which Siska and Emily will be talking about in a little while. So all exciting stuff. Next slide, please. I think we'd all agree that most of us are managing more and more challenging cases. They're quite complex. And I think what we've come to realize is that we can't do it. You know, we're part of a team, that we can't do it without the help and support of all key services. So we've developed an integrated approach to care through collaboration, and looking at each individual based on their individual needs to ensure that they have everything in place, almost like a wraparound care service, to enable them to start at the appropriate time, to make sure that they start treatment, complete treatment, so they're supported throughout to complete their treatment and beyond, and achieve, well, not just to achieve SVR, but also to prevent reinfection. So as I said, it's very important that we apply this multi-agency approach to care to make sure that we achieve that and improve the outcomes for all of us. As I said, most of them fall through the net. So what we're trying to do is tighten up those networks to make sure that they don't fall through. Next slide, please. So, as I said, it's still very labile, the situation. So we're making the most of the status quo. What's not so positive, Brendan mentioned the recent modelling, which shows that at current treatment levels, we won't hit it by 2040, let alone 2030. It's still very uncertain. We have new variants, Omicron, further restrictions. So again, we're having to be adaptable to and to try and sort of take advantage of what we can do in this situation. I know our NHS is on its knees, and a lot of clinical staff still being redeployed to the front line to help out. We have seen a rise in reinfection rates, but on a much more positive note, we do have a very highly motivated Always network, which was committed to Elimination Target. We had a very successful rollout of Bbv vaccines with amongst our vulnerable groups, and the Hep C peer-to-peer Follow Me project is, which is a pilot, started at the end of last year, which already is making a big difference. Next slide, please. So what next? As I said, from our national workshop in October, each health board set SMART objectives. We'll be developing their action plans. We've had some recent funding available from the Liver Disease Implementation Group /fund, which has provided opportunity for new case finding initiatives. And we've also set up a data collection steering group in order for us to look at our data collection processes. So at this point, we need to regroup and set an operational plan for our phase 2. Next slide, please. So elimination by 2030. Can we do it in Wales? The upside is we're certainly not short of the will. We have passion, drive and commitment. We're gathering the know-how. We have a very effective multi-agency working with our key partners. We have our peer-to-peer pilot program, which we hope will continue and be implemented throughout Wales. On the downside, actually, that's me on the nursery slope, and I'm not kidding you. What we don't have is adequately resourced teams across the board, unfortunately. So that's where we are. It's been a positive move, and I'm looking forward to the next phase. Next slide, please. Thank you.
Thank you, Dallas. That was fantastic. And I just wanted to say that I think the Task and Finish group has been incredible. The speed and the commitment in kind of the work that was pulled together from when it was set up has been incredible. And I know that feedback from the face-to-face conference or meeting that you'd managed to get in place was really well received. Before we move on to Danny, who is from the Hepatitis C Trust, who's going to talk about peers, I just wanted to remind people, if you have any questions, please do put them in the Q&A box or the chat. There is some time afterwards to ask some questions, to answer some questions from each of the presenters today. So please don't hesitate to put the comments or questions into the box. It gives me great pleasure now to hand over to Danny Morris. So Danny is the Midlands and West Regional Manager from the Hepatitis C Trust. And he's going to be talking to us about hepatitis C peer-to-peer support in Wales and where we're at today. Danny, over to you.
Thank you, Rachel. Thank you all. I just need to reinforce, really, we're absolutely delighted to be given this opportunity. The award from the LDIC, the National Liver Disease Implementation Group, awarded us this grant to deliver this peer project, initially in Cardiff, one that we plan to extend beyond and throughout other area health boards. But we're massively grateful to be given this grant to work and to really add capacity to build upon the notable successes that have occurred across Wales, regardless of all the kind of challenges that are there. So thank you for that. Next slide, please. I want to spend a few minutes talking about the Follow Me model, so how we work and how we've implemented it and what we've learned in delivering this project across England. We delivered this project, the Follow Me project, the peer-to-peer project, in 21 of the 22 ODNs. So the ODNs, the operational delivery networks, are kind of broadly analogous to kind of area health boards, geographically, as it were. And our projects are very closely associated with those operational delivery networks and very much integrated into the hepatology teams that deliver hepatitis C treatment. And it was first developed several years ago to provide support for people with little access, basically, to kind of services. You know, people who are marginalised, people who are very fearful, stigmatised because of perhaps their injecting patterns and behaviours, and stigmatised because of hepatitis C. But the model's designed in a way that patients basically follow people with lived experience of hepatitis C through initial testing all the way through to kind of treatment. And we've found over the years our staff have become increasingly embedded within local clinical pathways. Many of them, in fact, most have NHS honorary contracts to facilitate that and operate as part of hepatology teams. We work closely with partner organisations, drug services, homeless hostels, so on and so forth. So our peers are uniquely placed across those bridges, you know, and we know that people fall out, they don't adhere to the pathway. The peers are there and ideally placed to support that happening. There are three components to this, really. The first one is around initial engagement and awareness testing, and our peers are trained, so our paid peers, staff and volunteers are trained to deliver educational workshops based around their own experience. we can meet them through many kind of channels, through outreach provision, visiting hostels, working drug and alcohol services, setting up testing events and so on and so forth, just to raise awareness around hepatitis C. There's still a huge amount of ignorance amongst people who are at risk. You know, that's changing, but it's still very, very much there. And the workshops involve peer volunteers using their own story of having Hep C, of having an injecting history, former or current, and shaped to address common misconceptions about hepatitis C, you know, about how treatment works, the issues around treatment, and so on and so forth. What we're finding, interestingly, is that need to convince people of the benefits of treatment, certainly in England, because our experience is less and less needed now. I think what we found is the best way to promote Hep C treatment is to treat people. And they will then go on and talk to their friends and explain, one, how easy it is, and two, how beneficial it is. The peer support element, once we test people and they require our services, they're either referred from other agencies, the NHS, drug services perhaps, but those people that we contact, once we engage with them and they want our support and service, we will support them. We will allocate them a peer throughout the whole of their treatment journey and beyond. So it's not just up until 8 weeks. Yeah, we go to kind of SVR 12 and SVR 48. You know, so we will follow people through. We'll check depending on their need. We'll provide them with all sorts of support. It might be reminders about appointments. We may pay for travel or escort them, go and pick them up, for example, particularly people within rural areas. Often transport is very, very difficult, and we'll go and pick people up. Emotional support. I think it's very easy for us to forget sometimes, because treatment is so easy. We often forget, I think, sometimes that the impact this has on people emotionally is really, really significant. We work with people who historically have experienced, you know, years and years of kind of isolation, often self-imposed isolation, inability to kind of maintain relationships, for fear of passing on the virus, and so on and so forth. So there's a lot of work we do around that. You know, I've referred to this on a number of occasions, but it stands out. On an occasion when a young couple were crying because they didn't know, when they had their diagnosis, because they didn't know if they were allowed to cuddle their baby. Okay, that we have time, our peers have time to work with people around those issues and reassure them. Yeah. And that's an ongoing piece, an ongoing part of the work that we do. And additionally, in terms of added value, as our peers, because they're increasingly networked into the services that are around any one area, well, when time allows, often help people perhaps with benefits or referrals to a drug service for treatment perhaps, or support with housing. You know, it's a limited and arguably a light touch, but we are there to provide that level of work, maybe an application for a job and so on and so forth, you know, as part of that ongoing support while they're in our care. Okay, and advocacy, education and prevention is kind of key. Throughout this process, we advocate on behalf of our clients and on behalf of patients. We provide harm reduction support, we increase educational awareness. Increasingly, our peers are providing needle syringes, sometimes through our own resources, sometimes with support of a local drug service, for example. And that happened particularly during COVID, when services were shut down, pharmacies were restricting access. So there's a lot of work that our work is building in that arena, absolutely, in terms of preventing reinfection. And I think for me, one of the most powerful aspects of the advocacy and the influence our peers are able to have is in the change to the pathways from testing to treatment. And I know we've seen some significant shifts. I not uncommonly will speak to nurse specialists, hepatology leads, consultants, you know, who refer to the fact that they've changed a local pathway based on the input from our peers. And this is particularly relevant when we're talking about people who are much more marginalised, people who are going to maybe go street homeless and so on and so forth, who are going to find it very, very difficult typically to kind of engage properly in a pathway. So we've been supportive of adapting pathways to support the individual need, and sometimes doing things in reverse, as it were. So getting them onto test, getting them tested, getting them onto treatment, and then do them all the health monitoring that you'd expect to do ordinarily. Because sometimes for certain groups of people that works best. For those that don't need it, that's fine. But really proud of the fact that nearly all of the areas we're working in reflect on the fact that our peers have influenced really constructive change in the way that they actually work. Next slide, please. What is a peer is often kind of asked. This is a quote actually from a publication. We produced it nearly 2 years ago now, I think, about our peer work. And let me just read this out for those of you who can't read the tiny writing on the screen. So we're not hospital workers, we're not drug workers. We're not key workers, we're not people of authority, which is key here. We're just people who have lived through the same journey they're going through. We understand we're people who understand the powers of addiction and the stigma that comes with having Hep C. We're just there as a friendly face, basically. So they're not going through it alone. And that, it's a really powerful thing. Sometimes it's very difficult, actually quite difficult to describe, but when you see it, it's evident how powerful that kind of peer kind of role has. Okay, next slide, please. This is just gives an indication of the work that can be done. Okay, now this is not to compare what's going on in Wales. It's a completely different. It doesn't bear comparison. But this relates to the activity across those 21 areas in England that I mentioned just before. And in the current financial year, since April 2021 to date, we've trained, run awareness sessions in groups or one-to-one to over 24,000 people at risk. Okay, in those environments I spoke about, be it at hostels, on the streets, in drug and alcohol services, or wherever. Okay, 50.5 people asked for to be tested as a result of that intervention, and our staff tested 15,500 people. The technology varies. It might be a dry blood spot test. It might be using a Cepheid machine, as in the case here. Some areas are using capillary testing. So there are pros and cons to all those kind of technologies, but they're all being used across various areas in England at the moment with increased effectiveness. Out of those number of people who were tested, 2,200 odd people have been diagnosed with hepatitis C. That's who are PCR positive, by the way, not antibody positive. Okay, of which to date, over 1,600 have started treatment. I would anticipate over the next, literally next 3 or 4 weeks, that number will obviously go up as those people who have been tested positive are going through the kind of process of going into clinic to start treatment. Okay. And additionally, and it's quite an astonishing number, there's over 8,000 people in that time, the staff, professionals within the settings that we've trained and given awareness courses to. Next slide, please. And this is just an illustrative of the pathway, and I've put this up to indicate that people generally, this is an increasing challenge, I think, for us, and increasingly requiring support along this pathway. And I think the lessons we've learned from this is that the people that are relatively easy to treat, i.e. people within drug treatment services, for example, when there's some level of support, these pathways arguably could be easier. They're much more challenging to a significant number of people outside of treatment who are at risk of hepatitis C. Brendan touched on this, people who may have injected previously, who gave it up a long time ago, people who are disengaged from services. I must admit, I don't have a handle on the Welsh data particularly, but certainly in England, on average, if you, in any one area, 50% of people will be in treatment, 50% will be out. And that varies. Sometimes it's 60-40 one way or the other. But that's a community that particularly through outreach has been touched on here, and I'll explain the stuff that we've been doing locally in Cardiff. We need to reach those people who are most at risk. And those are the people who are with multiple needs, multiple difficulties, who are less likely to turn up to appointments. Right? Are often unwilling to have bloods taken. Yeah, because it's humiliating having somebody draw blood from you, when you've got no veins left. Right? And of course, skilled nurses, practitioners can draw blood, but people's experience is often very, very negative. And that in itself is quite a huge barrier for people. Okay. And again, having peers testing in that environment, this is no disrespect to the professionals at all. Yeah, there's something about the kind of language and the conversations that could be had. People who inject drugs largely are stigmatized. And that doesn't go away, although, as we're discovering, getting people through treatment can have a profound effect on how they see themselves and the changes that could be on in their lives. So we work with these pathways, and we are, I think, proud of the fact that we can accelerate this for people in need, and the benefits are huge. The downside of not being flexible with pathways is that you will lose people, and that's our experience. Okay, next slide, please. So this comes from that Leave No One Behind publication I mentioned just a few minutes ago. There are many here. This is Sophie, who was a client, a service user, a patient who completed her treatment. It was the first time I'd actually completed anything in my life. My confidence built up a little bit speaking to people. Through the support of Rachel and Imran, I've become a peer myself. It's fantastic. The journey, you couldn't make it up. It's been amazing. We are continually getting feedback from people that we support through treatment, because often for so many of them, it's the first time they've engaged in a constructive and healthy way with healthcare and social care provision. And I think, again, it's the peers that enable that interface and sit people down in front of a nurse, in front of a consultant. There's no fear. They understand it. They know that if things get challenging, they have a voice to support. Next slide, please. So where are we in Wales? I'd like to introduce here kind of James Bolden here is kind of centre, kind of top right. He's a peer support lead, managed by Kieran, who's a peer coordinator. Both of them started in November. I'm delighted to have them on board. Kieran's is supporting James. James is doing most of the stuff on the ground, basically. And Kieran is doing some of that, also supporting him, overseeing the training development and coordination of the project overall. Okay, and ensuring that we meet our project aims and objectives as we've committed to do across Cardiff, Vale and University Health Board. Now, initially, the work is going to be in Cardiff. I would anticipate, and our plan is in the next 3 or 4 months, much more of that work will be done across other area health boards, and I'll talk about that shortly. So where have we got so far? We're in the middle of getting an honorary contract for the two of them. I expect that to be signed off very, very quickly in Cardiff. We've recruited in November these 2 peers with lived experience. They're already running weekly awareness raising and testing in Cardiff's main homeless hostels. The uptake has been great, and interest is looking really, really promising. And there's training being offered to staff. This is on top of the training that Del mentioned. For example, Del has delivered some really comprehensive training to staff across the board, and that is still there. The training we deliver is much more from a service user perspective. So it adds another dimension, really, to the kind of training that's available. And at the moment, we're supporting 13 patients into treatment. There are several virtual training sessions occurring, in the long term, hopefully face-to-face, but in the current climate, that's much more difficult, obviously. James here is spending evening sessions with Salvation Army Outreach Services, meeting service users, providing harm reduction advice, and offering testing. And again, it's a very clear indication of the partnership work that's been referenced here a lot. I think there are some major resource challenges in Wales, unquestionably. But one of the things that clearly stands out is this inherent partnership working. And that's very, very apparent from the way that both James and Kieran have been welcomed, really, as part of this whole kind of system. There doesn't seem to be barriers in that regard at all, which is really, really encouraging. Okay. We've got links with Voices Action Change, part of Recovery Cymru for partnership working and peer developments. They're looking at helping us develop our peers as we recruit them. We've got a couple of peers recruited at the moment that we've trained and have signed up onto our systems. There's been plenty of testing going on at Diffodol and various other services in Cardiff, assisting the local nurses, as Del has kind of mentioned. We're setting up testing events across various kind of systems, and also responding to kind of follow me prison releases. We don't have, I'll mention this, go on to this shortly, we don't have prison peer support formally in place at the moment, but we are in Cardiff providing support for people who are released into Cardiff from relatively local prisons, perhaps in England even. But we're picking up on those already and working with the prison teams that are referring into James and Kieran. Next slide, please. I'm mindful of the time. It could be a couple more minutes. So, get my slides up so I can read my notes. Part of our success, undoubtedly, is the establishment, when we first started, before we actually recruited, was setting up a project steering group. This was led by Gareth Morden, the commissioning manager, Cardiff and Vale UHB, and is represented by Del Tompkinson, Matthew Evans, Cardiff Councils, Simon Amphlett, Senior Nurse of Substance Misuse Services, who is going to be hosting my colleagues, in terms of a physical space. Nikki Palmer, National Hep C Project Lead and Research Nurse at Public Health Wales, who's we're working with in terms of the data collection. And Sarah Vale, I mentioned, as Director of Recovery Cymru, is offering to support our peers, more kind of comprehensively. Which, so it's already this steering group has enabled us to network really, really effectively in a relatively short period of time. I must also acknowledge that certainly Kieran has worked in Cardiff and knows Cardiff well, so we were very lucky that he understood those systems. James is from Pembrokeshire originally, but again, in terms of it's really, for me, in terms of management, knowing that I have staff that really understand the culture in which they're working is a major advantage here as well. And the project steering group very much underpins all of that. Next slide, please. So where next? Which is an interesting question, I suppose. Well, first off, we are starting to have conversations with other area health boards. So the longer term objective of the project is to stimulate the growth in similar projects across the other area health boards. Okay, we've already had contact from services in Powys and Bessie Cadwallader. I hope I've said that right, my apologies. And indeed Swansea. So there are areas of generating interest. We were able to offer comprehensive training across all of those areas. As from now, we have a training lead who will deliver training when asked across all of those areas. Jamie, I'll let people have more details around that. So certainly we want to start developing relationships, and that's happening in the background. The focus at the moment for Kieran is to get the Cardiff project up and running, so we can learn and understand and then use that as a benchmark really when we're developing in other areas. Okay, so that's the aim to develop something broadly similar across those areas to stimulate local funding to support peer projects. Okay. I think certainly initially in some of the areas that have had contact with me, we're going to be in a position to train service volunteers, how we can support them at a distance around Hep C, to support those Hep C volunteers, Hep C Trust volunteers. Undoubtedly, that will be the first step, certainly. I suppose for me, the very significant thing here, which is outside of the immediate remit of this project, but something I heard good news about from Sean Cox, who's Director of Prison Services this morning, is there's been a major advance in developing a prison follow me service. Okay. It hasn't been confirmed. There's many of you who may have been at a recent Hep C conference in Wales a couple of months ago, we're clamoring for having a prison peer lead or prison peer service. It's been a hugely successful exercise in England, and we're hoping to replicate that here. And my understanding is that is likely to be happening in the coming months. So obviously, Kieran and James will be linking up to any of those workers in terms of supporting prison releases into the community to ensure that there's continuity in terms of people's treatment and care. Next slide, please. That's kind of it for me, really. I just want to thank everybody. Looking forward very, very much to developing this work more. I'm very grateful for James and Kieran for kind of running so readily since they've kind of landed. What they've developed so far has been hugely encouraged to us as an organisation, and looking forward very much for developing it further. Any questions? My email address is here. Thank you.
That's fantastic, Danny. Thank you very much. And I think that anybody listening will have picked up on the enthusiasm, not just of Danny, but us at the Trust, of being able to deliver peer services in Wales. And I guess just to acknowledge that, how thankful we are, how grateful to have the funding, but also how welcoming, the incredible teams have been. Part of our work in Wales, obviously, is around substance misuse services, and I'm really happy to introduce to you now Michael Curtis, who's going to be talking to us hepatitis C and drug services. Michael is the head of substance misuse with the Welsh Government. So, Michael, welcome.
Rachel, thank you very much. Yes, some really interesting presentations, and they're going to be quite a hard act to follow, but one I will do my best to do. So if we could have the next slide, please. Just think it's really important to remind everyone that in Wales, we are lucky in that substance misuse is very much embedded as a health issue with the harm reduction approach. And I think that does give us a really strong foundation from which to work towards supporting the delivery of the World Health Organization Elimination Target. It's really interesting to hear Danny's presentation around developing peer-to-peer support here in Wales, because we've got a strong tradition of services that are peer-led. So we have a peer-led employment program, a peer-led naloxone pilot, and it is certainly something that is really important part. And I recognize many of the points that Danny were making around stigma. And I think it really, going back to some of the other presentations, one of the things that we are seeing in substance misuse services is this term, people are very complex, far more complex needs presenting at services. And I think we have to realize that we have to have a flexible system that works with those people, because their complexity drives what is their priorities for them. And it needs that understanding and that flexibility to work with people. And I think our partnership approach here in Wales really, really supports that. So BBV, and obviously supporting the hepatitis C elimination target, is a key part of our pathways for treatment here in Wales. And I think it's really important that as we've been working through this over the last few years, we're really clear it should be routine. It shouldn't be an exception. It should just be the routine. This is what happens when you come to substance misuse treatment. And if you don't say yes on the first day, we'll come back until you're ready. A number of years ago, it seems a lifetime ago now, we introduced a Bbv testing target for our substance misuse services here in Wales. And they agreed to set a target of ambitious target, making sure that 50% of all people accessing our substance misuse treatment services who were eligible were tested. In the first year, that was fantastic. We had, from what was quite a low base, we had a really sharp increase in people being tested and supported into treatment in Wales. Unfortunately, as we all know, to the end of that first year, the global pandemic hit us, and that has really had a huge impact. But we did get up to 38.9%, which was really great in terms of the number of people who were offered, and then people who were tested, 33%. So it was a really good start. And obviously all of that data is now recorded through our harm reduction database, which was mentioned earlier. If I could have the next slide, please. As I said, unfortunately, COVID has hit us and is still with us, and that has had a really significant impact on substance misuse services here in Wales, as well as all other health services. Our OST prescribing services have always been classed as essential. We lost a lot of face-to-face support as a result of the COVID introduction. And as has already been stated, sadly, we virtually lost overnight our Bbv testing capacity here in Wales for very understandable reasons, but it, was a significant blow to everybody. On a more positive note, our services really held up well in terms of supporting those people who are in the greatest need at those really difficult times, and particularly around the significant effort to bring everybody in here in Wales. So we had over 800 referrals in the first couple of months from people who were brought in off the streets, of new people into OST prescribing services across Wales. So those services continue to support people. And a lot of those people had not been in touch with services before. So actually creates a new opportunity. We've got people who are housed, we're supporting them, we can engage them into treatment. And that is a big piece of work that continues to this day. One of the things where Wales was quite unique in our response to COVID was the introduction of support nationally for injectable buprenorphine. And that was initially to support the social distancing and isolation requirements because of obviously the lack of requirement for day-to-day supervised consumption, but that has actually resulted in quite significant difference to the way we may choose to deliver substance misuse services in the future. And I think one of the really positive things that has come out of that is that we're seeing an awful lot of people who are having really positive outcomes, which gives us lots more opportunity to work with people in a positive way and address a number of priorities, including a range of physical health problems. And I think one of the advantages of being based in health is that we don't just look at people as having a substance misuse issue. At the end of the day, people have a range of health issues, including Bbv testing requirements, hepatitis C, etc. So we have to have that holistic response to supporting people going forward. Next slide, please. I think one of the more worrying impacts of COVID, and I know this isn't unique to Wales, is the significant drop in the number of people accessing and using our harm reduction services and needle and syringe programs. And that is something that is a continuing worry, and we are working with our harm reduction leads across Wales to see how we can address that and make a recovery from that. But as you can see from that, a really significant reduction in the number of individuals accessing those services and the number of syringes provided. So a real risk that we have out there within our population of people that we're supporting, and there could be a lot of factors behind that, but that is something that we want to continue addressing as we start hopefully to see a more sustained recovery out of the pandemic. Next slide, please. Okay, so we also know we've got a big problem, you know, over almost 45,000 people estimates who are problematic drug users in Wales, which is a long way off the number of people that we have in treatment. So something that we really need to focus on is making sure that we get more people into treatment and into those pathways to support them, including testing for those people who need that. Next slide, please. We've talked about the stress on services, and you know, have to acknowledge that that's obviously is the same for substance misuse services. So for some of our prescribing services, we are beginning to see an increase in waiting times and waiting lists for treatment. That is a worry. You know, the longer somebody isn't in treatment, the greater there are risks for them. We had before Christmas been thinking that things were beginning to get a bit better. Obviously Omicron hit, and that has had a major challenge. I think the good news is that it, as everyone is saying, it seems to be calming down a bit more, but we know we have a huge amount of work to do as services begin to adapt going forward, and we begin to look at how we deliver to those people who most need those face-to-face services, how that continues, and we make sure that those people are prioritized. I think it's also worth saying, given that our substance misuse services cover both alcohol and substance misuse, that we have a significant increased number of people coming into services through alcohol consumption. So that's another pressure on those services, again, alongside the fact that there's increasing complexity. And we all know that navigating around a health service for anybody is really challenging. So how we support those people, and I think the work that Danny's talked around about peer programs and the dedicated Bbv teams is really important to supporting those people who've got a range of complex needs. Next slide, please. So we've continued to support our area planning boards throughout the pandemic. I think they're really critical. You know, they are part of our partnership working. They all host the harm reduction leads who've been mentioned a couple of times, who really play an important role in this work for us going forward and coordinating that for substance misuse locally. We made over almost £5 million of additional funding available to support our services throughout the pandemic. I've talked about Vale. one of the things around Buvidal, as I said, is that it's been really successful. We have over 1,000 people in Wales on Buvidal treatment, and that is increasing as we go forward. The work with housing, our housing colleagues, and the large number of people coming through that route, and that is up to about 8,000 people in temporary accommodation in Wales now, is a real big priority area for us, and actually a big opportunity as well as a big challenge. We're working very closely with HMPPS, health colleagues and Public Health Wales in developing a substance misuse treatment framework for prisons that will be going out to final consultation soon. And that also includes the need for Bbv testing within those settings. And we've funded further Bbv testing capacity within both the prison environment and the community environment, but actually in many cases with dedicated machines within those settings. And what we did do during the pandemic as well was revise our delivery plan to reflect some of those emerging priorities. Next slide, please. So to end on a really positive note, the draft budget was published before Christmas, which will see an overall increase of almost 24% to substance misuse funding here in Wales, which is really fantastic. That will see an increase in funding both for area planning boards and health boards, and our complex needs funding, which specifically targets those people who are in contact with housing services, is being doubled. And I mentioned Buvidal. In terms of that, we have actually got a 3-year commitment to that treatment, which gives our clinicians far more stability and will begin to allow us to understand what that treatment looks like. Going back to a point that Brendan made, one of the barriers sometimes seen for Buvidal is it's significantly more expensive. But actually, if we're seeing really better outcomes, then we think it is something that is worth considering going forward and keeping as part of that mixture. I think that is everything from me. Yes, thank you very much. Diolch.
Thank you, Michael. It was really, it was a great overview, and also really reassuring to hear that there was an increased investment into the drug services. I think that we all know that, you know, that the COVID has impacted on drug services in all countries across the world, and Wales is no different there. But I guess the thing that, something that Della said earlier, and I think Brendan alluded to it, was reinfection, you know, and, you know, the people not accessing needle and syringe provision is really important to address so that we can kind of get a handle on reinfections. But rather than come to that now, there is an opportunity to ask questions. Please, if you've got any, can you put them in the Q&A box? Just before the questions though, we do have hepatitis C elimination children and young people in Wales. With the access to DAAs now being available to young people and children, it's a fantastic opportunity that we have today to hear from Dr. Siski Struick, consultant paediatrician at Cardiff and Vale University Health Board, and Emily Blake, who's a paediatric Bbv CNS nurse in Noah's Ark Children's Hospital. So over to you both.
Thank you. Yes, exciting to be here. I'm going to start the talk, and then I'm going to let Emily speak in the middle to give an illustration of what this is really like at the moment, working with families. It's a very short talk. However, I hope it will be thought-provoking, and so please put things in the chat. I will put my email address in the chat as well, because we are really at the beginning of a new piece of work here. And I hope that sharing it with you will help it take off and get some arms and legs. Can I have the first slide, please? So you might ask yourself, can we actually treat children with Hep C? The answer to which is yes. From the age of 3, we can treat them now, as in treatments are licensed, and more is coming on the market quite quickly. So It's guided by what genotype you have, also by your weight and by your ability to swallow pills. And this is where Emily comes in heavily, because you may not know this, but children from about the age of 5 can fairly easily be taught how to swallow pills. And this gives us more options for treatment. And that's true for lots of diseases, but it also is true for Hep C. If they cannot do so, then there are now granule products coming on the market as we speak, really. Next slide. So, do we have children with Hep C? The answer to which is, I think so. We have a small cohort ourselves, and we're pretty confident we're missing lots of people. So if you think about how children under the age of 16 would usually have acquired Hep C, then the biggest group will be, that we know of anyway, will be those who get it in pregnancy from their mothers. It's not a high transmission rate, so approximately 5% of children of Hep C positive mothers will acquire it. But if you think about the numbers, we know certainly from data in Wales that about 60% of people who substance misuse are parents, and their average is about 2.3 children. However, many of those children do not live with their parents. Herein lies some of the difficulty of oversight. We have currently no systematic way, and we're not alone in that in Wales, I know the same is true in England, to register the testing of children, of adults who are diagnosed with Hep C. I know that in our service in Cardiff, we do ask the question, do you have children? And we encourage them to be tested. We don't see it through to the conclusion of a positive or negative test. And so that's an unanswered, is something we really need to give some thought. We also have no universal testing in pregnancy, and this is true for the whole of the UK. For Hep C. And so what that will take is for a midwife to make a risk assessment as to whether a woman should be tested. And in practice, what it means is that only those who are already known to substance misuse services locally will be put forward for testing. And even then it's often not fully completed. What I want to say to people who look after adults is that the advocacy duty for children is different, and this has to inform how we go about the services. So if you are working with adults, ultimately if they don't engage, that is down to them, and we do everything to encourage them, but it is their own personal decision. For children, that's different. It's the professionals, and by that I include everyone, not just myself. Professionals have an ongoing responsibility to children when parents don't facilitate their engagement with health services. And so it doesn't end when the parent disengages. We share that duty legally to try and facilitate accessing and supporting the children and their families. And that's a really important distinction that informs what I think needs to be done. So that's the first group, the parental drug drug use. The second group is young people themselves who are in substance misuse services or not, but who are using intravenous drug. That's another way they can acquire it. Probably relatively low numbers because they're still young and it takes time to meet your odds. And then there's an important group of those who are immigrating into the UK from areas of the world where they may have acquired it through health services. And so iatrogenic infections. And that's another group that we're not really got a handle on, certainly not here in Cardiff. And then there's the small print of potentially transmitting at other points in life through what I've listed there, razors, tattoos, piercings, sex, toothbrushes. Those are true for everyone, and that includes children. Next slide, please. So we do have some, but we think we're missing a lot. I oversee the whole of South Wales, and that includes 5 health boards, 9 paediatric units, and therefore 4 clinic locations. And that's only a cohort of 9 patients. I've only been involved in this work for 3-4 years now. The oldest one that I've listed here was a classic motivator for getting asylum seeker services in place, because this child, when she was about 13, presented in crashing liver failure, and it took us a while to figure out that that was driven by Hep C. She was treated and she has cirrhosis, but she no longer needs a transplant. The whole of the rest of her family negative, so this is almost certainly from hospital admission that she does remember. Many of our other children are living with their mothers and are acquired through, have acquired it from their mothers. I think that's a bit skewed by the fact that those are the ones that are relatively easy to keep hold of. The ones that acquired it from their mothers but were adopted or moved on are much harder to keep in your services. And we have indeed lost in an audit when we looked at this recently, well, a couple of years ago, we lost another 6. So that's only 15 children. That's nothing compared to the numbers you guys are dealing with. I realise that, but it's also not everyone. Because if you did a calculation on the back of your envelope, and you know that 5,000 adults have been diagnosed in Wales, then if you were to assume that half of those are female, 60% are parents, the parameters I said earlier on, then we should be having 75 children on the book, not 9. And so we do have some work to do there, and we're keen to do that, particularly because it makes such a difference for these children to be treated. Can I have the next slide? And you know, they don't know that they're at risk, so we need to come find them. So the next slide is about what is it like to cure children with Hep C. Well, it does affect, in the same way that it affects adults who vouch for this, that their treatment does improve their overall physical well-being. It's like you're no longer chronically under the weather. And in children, it will impact on behavior. And there are also studies to show that suggest that it improves their educational attainment. That's massive. These families are vulnerable. They move around a lot. They're hard to keep hold of. Case finding has all sorts of challenges because there's lots of areas in which we should be looking for them. Follow up. Now, I know that in the sort of settings you work, it can be a problem keeping hold of somebody for a couple of days, weeks. What we've been looking at here is trying to keep hold of people for 12 years who have to come to appointments, etc. And so now that the age of treatment is coming down, this will be easier, but it's still, you know, several years of having to hold on to families. And these families, particularly if it's been acquired within the family, live with massive guilt and stigma, but also adoptive parents do experience those sort of feelings too. And this is where having the relationship and the trust with a constant figure is really important. And I feel this is one of the main contributions that our clinical nurse specialist makes in a way that I can't. I'm gonna just pause here for a second and let her speak about the recent experiences of telling some of our families that they could now be cured.
Hi, I'm Emily. I haven't been in the role for that long, so as Siska said, we're still sort of finding our feet sometimes, but it's so important to build a rapport with these families, because you are looking after them and supporting them through this. And the mothers, as Siska said, just feel a huge amount of guilt. And these are families who have been through drug addiction, but they've come out the other side. And so we're looking after the ones who are a bit more stable, and so they are easier to look after and keep in touch with. But you have to still sort of really focus on family-centred care. And a lot of these families have had social services involved with them, and they're terrified of social services, which we all know that they shouldn't be, but they are. Again, it's the whole stigma. And now we have got a cure for hepatitis C. You sit down with families and they have had stigma from everyone. Hepatitis C isn't really spoken about very much, and so the families don't talk about it either. And the less we talk about it, the greater the stigma there is. And so by educating people, social services, health visitors, hopefully this stigma can be reduced. But one family in particular, the child has been adopted, but so not only are they living with adoption, which can cause problems for the child within the school, they've also got the added hepatitis C label, as it were, when they go to school. And I recently sat down with this mother, and she knew that there was treatment around there, but she hadn't sort of put 2 and 2 together, that once this child is treated, she will be cured. And you could just see the weight coming off her shoulders, and it was amazing to see this, that she knew that this would be one less thing for her to have to worry about, that her 4-year-old daughter could be cured from hepatitis C. And knowing that they tend to engage with you a lot better. They come to their appointments because they want this. They want to, the guilt that they've been carrying around can finally be removed. And so they just are really up for coming to appointments and for their children to be cured. And even though they know that they'll sort of have to have more blood tests during this time, they know that the end result is that they will have this, the stigma will be taken away, hepatitis C will hopefully have been cured, and as Siska was saying, they will hopefully have better concentration in school and greater educational attainment. But we do need to build up that relationship with these families to enable them to get there. And as Danny said, if we can treat these people, they then will go and tell other people who they may still be associated with about hepatitis C and how it can be cured. And hopefully we're one step closer to elimination. Back to you, Siska.
Okay, can I have my last slide then? Yeah, so hopefully that gives a clear picture of why we should be out there trying to find these children. It's also true that, of course, the ones that are at risk and don't know that they aren't going to feel the consequences for a couple of decades. And often finding them via their parents is an opportunity to intercept, years of potential damage without unbeknownst to themselves. So that's coming back to the advocacy. So in terms of how we are organised, we're very much a hospital-based clinical service. Originally, and this is before I was involved, it was led by and actually delivered in Birmingham and London. So this meant that these families had to travel on the bus all the way there a couple of times a year. And occasionally, well, there was some outreach, but that would still be in Cardiff. And if you know the map of Wales, Wales is big. Cardiff is also a long way for lots of these families. So the DNA and the loss to follow-up rates were massive. In fact, that was the rule rather than the exception. And, I trained in paediatric ID, and I moved to Cardiff some years ago, and I've always, in my training, looked after these children. This was in London. And so I sort of self-appointed myself as the to-be-formed network lead. And this was really to look after those we already know have Hep B and Hep C. And so we've come a lot closer to having them all back under our wing. we've still got a strong link with Birmingham, but we do a lot of it virtually now, and that allows us to build the direct relationship with the families. When I say us, that is me and Emily, but Emily does the big part of the building that. And yeah, we do, as I said, collaborate with England, and that's also for clinical governance. But and we share all the treatment decisions with them. We haven't really worked out what to do with what's happening in the north of Wales. Can I have my final slide? And so thinking about what we have a small clinical service. We have retraced most of our patients. We are working through curing them, but you know, there are so many out there that need it, that don't have it. We think we need a way of getting a register. So anyone who's good with databases that are collecting adults, we probably need to speak to them about how to approach this. We also need to improve uptake in pregnancy. We need to be liaising with young offenders and substance misuse services, immigrant screening, you name it. But really what that means for hospital-based doctors, that a lot of public health work that we are absolutely not funded to do. I'm not also not funded to do the clinical work. I do this in personal time, but it's a small group. And it's for us very broad in terms of who we should be working with, because this spans the whole of Wales, because it's a small service. So there's 6 different health boards, and within those different services, maternity, paediatrics, CAMS, asylum seeker services, prison services, you name it. And then at national level, we, you know, funding public health. So to actually do this effectively from a tertiary children's hospital, we'll need some thought and some support really from people who know how to do this. And I also would love to work a little bit closer with the Hep C Trust on, for example, on putting some more information about children on their website or whatever else they think adults access for information, because those adults need to know that this is possible. I'm going to stop there because I'm aware that we've done our time, and I want to hear what other people think rather than talk anymore. Thank you.
That's fantastic. Thank you both so much for a really important presentation, really important. Something very close to my own heart. When I first joined the Trust, lots of children, there wasn't the treatment for children then. And yeah, this is really important. It does strike me that perhaps there needs to be more awareness, general public awareness, but I think your shout out there was heard, Siski. Definitely we can support you with the Hep C Trust. Brendan actually wrote something in the messages here saying, from a database perspective, the Hep C form could be used. So hopefully you can contact Brendan and it can all be tied in. We actually are out of time, but if people are happy to stay just for a moment, oops, we've got another comment here from Chin Lee. We proposed for universal Hep C testing in pregnancy back in 1999, yeah, but it was turned down as then no effective treatment. Given the better treatment, I think we perhaps should think again. Absolutely. There's a review happening now in England, and I don't know whether that would follow on in Wales as well. This is the opportunity now. It's insane that universal testing does not happen within antenatal. Hep B is tested for, HIV is tested for, but no Hep C. Really important. So just as we come to the end now, and as we have run out of time, I just wondered whether no one has asked a question. Actually, there were just a couple of comments. So there was just one question I was going to put to all the panelists, if they were happy to answer it, if I can find my question now. So what do the panelists feel are key areas that need to progress in order to achieve elimination? I think finance funding is the top one, but I wonder whether I can ask Brendan. I can't actually see anybody, but Brendan, top thing, Brendan, data, funding, is there anything else?
I don't think there is a top thing, to be honest with you. There's a number of things which need to coalesce, come together so that we can achieve elimination. And that's really about delivering testing in all the relevant settings, achieving linkage to care in all the relevant settings, making sure treatment is readily available and delivered at a place where the individual is easily able to access it, helping people complete treatment, and then having a method for testing them to prove cure. You know, that's the pathway that we need, and we need that pathway in lots of different settings. So if you were going to pick one, I think you'd say central funding to coordinate delivery of those pathways in all of the various different areas.
Yeah, I think that from everything we've heard today, though, there is a lot of, you know, the work that's happened in Wales, in spite of not having central funding, is really quite incredible. And one would think that just a bit of central funding that could tie all this together, Wales could achieve by 2030. Delith, is there anything else that you'd like to just add on the end?
No, not really. As you both just said, that I think we just need, obviously, like an elimination budget would be really helpful, and for each health board to identify what is needed and actually set up a dedicated elimination plan for each of the health boards, because each health board has different issues and different challenges.
Yeah, no, I think so. Michael, is there something that you could feed in as a part of the Welsh Government? Do you think that there's an opportunity? I mean, there's more funding going into substance misuse, which is, you know, definitely much needed, but is there the possibility of more funding or a central pot of funding for hepatitis C? Sorry to put you on the spot.
You have put me on the spot, haven't you?
I have to ask. Someone has. I mean, I think it's important to ask.
Yeah. And I guess what I was going to say is I think it's important people do ask, because sometimes people don't. So I'm more than happy. Maybe that Brendan has already had those conversations, but if that there is some point in picking up those conversations again, I'm more than happy to try and help facilitate that. Because I don't want to just address the funding issue. I think, you know, what we have heard this afternoon is about the really strong partnership working. And I think building on that is really important. And I think perhaps breaking down some of the barriers between professions and really recognizing the really valuable contribution that absolutely everybody can make to this agenda is really important. And I know a lot of that work is already happening in Wales, but particularly when you're working with a group of people who are so stigmatized, having a workforce who work together and challenge that is really important.
Yeah, no, absolutely. So just as we're reaching the end here, I wonder, Danny, is there anything else that you'd like to say as we are nearing the end?
Obviously, I agree with everything that's been said in terms of resources. I do hope we have the opportunity to build the BID programme to at least maximise and increase capacity when the resources are limited. You know, it won't be the total answer, but we've seen how it works elsewhere, and we can certainly eat the best by supporting kind of colleagues in the system. We can certainly get more people tested and treated as part of the solution. Yeah. Absolutely.
Yeah, it's part of the solution. So, Siski, is there anything that you'd like to add on the end, or Emily?
So, yeah, well, grateful to be invited. I think the more people know that we need to be getting going, the better. I could really do, as a clinician, I could really do with somebody who helps with the coordination, because as you can see, we need to be interacting with lots of different services to make it fit around the people who are in different places, and then ×6 health board. So that coordination will be a bit of a challenge, and it'd be good to get some help with that.
Do we have a like the HIV action plan, a national delivery plan that's similar, which is funded?
Yeah. So I need to learn how to get in there, I suppose.
So
So
I
I'll
think
speak to you now. Yeah.
Sorry, just to answer the question from Del about a national plan. I did write a national plan some time ago, and it was submitted, but then the response was that it wouldn't be centrally funded, and the rationale being that no other disease process is centrally funded. So that plan was written, but not funded.
The HIV one is it?
The HIV plan, I'm not sure, that's this year,
The
isn't
national
it?
one.
The you're
I
talking
don't think
about
it's this year's.
are you talking about the oh, what's it called? I forgot what it's called. Can you remember, Del?
No, I just know it as the HIV action plan. I think is it planned to be published in 2022, early 2022?
Yeah, I'm not sure about the funding
Yeah.
about that, to be honest with you. Michael might know.
Yeah, not sure. But certainly I think keeping it on the agenda is really important. So we keep the momentum going, keep the interest going. As I said, you know, we're all committed to this, but we're way behind, and the will is there. We just need things to fall into place to deliver.
yeah, and I guess, Michael, as you said, that you're happy to support. So you have that here. Siski has written, you wrote your email in the chat box. So if anybody can help at all, please pick up the email address. And this has been recorded. So there's an opportunity to pick this up again on the HCB Action website. I just want to say thank you so much to everybody, all the presentations today. It's been fantastic, really exciting, the incredible work that's happening in Wales. I wish I could wave a magic wand and say, here's all the resources, because they're just, you know, there's so much good work going on that I believe you would very easily hit elimination. I just got a message here from HCB Action. If everybody could, if you have an opportunity, please, there's a survey at the end. If you could write it, give some feedback on the sessions, that would be really appreciated. So finally, thank you again, everybody, all the panel members. Thank you for your presentations. It's been a great afternoon. I wish you all a great evening and look forward to seeing you all again soon. Thank you very much.